Go. All right. Well, welcome everybody to today's coffee chat, our April coffee chat. As you all know, I'm sure we have Rosie Bartel with us today, and she recently received the Barrel Institute Patient and Family Innovation Award, and we're so excited for her, so happy. She so deserves it. And she's going to talk to us a little bit today about how she got to this point, her milestones, and hopefully inspire some of you or all of you to be involved in your organizations too. So, but we will start off with a fun little check-in question. I love finding these and coming up with them. It's one of my favorite parts. But today's question is, if you had your own late night talk show, who would you invite as your first guest? Now I'm going to start off with Danny as a podcast host also. Who would you have as your first guest on your late night talk show?
Rosie.
I just
That's a great guess.
Thank you, Danny.
Thank you. Paula.
I'm still thinking. There's so many people. I've often thought about having a dinner party, and my ultimate guest would be. There's so many, and right now I'm reading a biography of Queen Elizabeth, so maybe Queen Elizabeth.
Ooh, that would be a good one. Let's go to Lori.
I would, like Paula said, there's so many people. I'd love Einstein, but he's not around anymore, so that's not going to work. So I guess Hugh Jackman.
Oh, yeah, I'd have a conversation with Hugh Jackman for sure. Let's go to Marty. Maybe. Marty, you're muted if you're giving us your answer. We'll come back. Come back to Marty. Cheryl, who would be your first guest?
The first person that popped into my mind was Michelle Obama, because I think she was such a beloved first lady, and as a mother, and has something in that role. So that's the first one that popped into my mind.
I love that. That's a good one. Roger and Lindsay.
I would invite Steve Burrows, and Steve Burrows is a producer. He's from Wisconsin. He did a lot of comedy. He was on Laugh-In and Funniest Home Videos, and he did some work with Saturday Night Live. But he's now very, very famous for the video that he did about his mother's medical error and death. It's called Bleed Out, and if you haven't seen it, you need to watch it. It's an HBO or YouTube, or you can get it a lot of different places. I think I saw it on Amazon Prime too, Prime. So, but he has done a lot of work now in the area of medical errors and medical emergencies, and he and I have been trying to connect since just as COVID was starting, because after someone sent him my book, and then he reached out to me, and since then we've been trying to connect, and because of COVID we have not connected yet. So he would be the person I'd invite to my talk show.
That's great. Yeah, I still need to watch Bleed Out. That's on my list for sure. Lindsay.
Yeah, hi everyone. I love this check-in question. I'm going to
shamelessly steal it, Laura.
Go for it.
I was trying to think about this too, and I was thinking like either alive or no longer with us. And I thought another talk show host would be a really good person to have on my show. So somebody like Johnny Carson or, Jimmy Fallon, they have met with so many different people and probably have a lot of really great stories to tell. So those would be mine.
That's a good answer. Yeah, Johnny Carson would be great. Jimmy Fallon too. I love both of them. Roger, hello. If you had your own late night talk show, who would you invite as your first guest?
Hi, everyone. Roger LaCoy here. Rosie, congratulations.
Thank you.
You are one of a kind, and I'm glad that you're on our side, honey. Thank you for doing what you do all the time. So, to you. If I had my own late night talk show, who would I invite first? It would probably be my husband, because I have to find out why he stuck around for 29 years, because I must be doing something right. So yeah, that would be mine.
That's cute. I love it. Lois.
I would invite Putin to be there. I was a former psychiatric nurse, and I'd like to see how stable he is.
Lois, only you.
I know. Congratulations, Rosie. I'm so proud of you.
Thank you.
Keep up the good work.
Amen.
And we've got Ting.
Yeah, I probably won't be staying late because I'm an early sleeper. But if I do stay late, I would like to have Danny talk about everything he has been doing.
Yeah, thank you. And Marty, are you able to let us know?
Yes, I am. I'm sorry, I had an urgent call.
No problem.
I think I would actually, if I had someone, I have a friend, and I think some of you know him, Barry Nelson, who has, he's had an incredible story, and he's doing incredible work. And he brings such a diverse and unique experience that I would like to have him to share. But I also would probably like to have Rosie, because I was talking with Tony Serge the other day. I'm doing a lot of work with him. And our big topic of conversation was Rosie and her wonderful work. So it would be hard not to include her as a two-person guest list.
I love it. Did I miss anybody? I think I got everybody. Nope. All right. Mine would be, and I've obviously had time to think about this. I would invite Lin-Manuel Miranda, who wrote Hamilton and the music for Encanto and Moana. And he's just, I want to know how his brain works. He seems such a genius. I just want to know how his brain works. So I would have him as my first guest. And I'm just such a fan. So that's who I would pick. Moving on. I'm sure all of you know Rosie. We don't have to meet her, but we know her and love her. And like I mentioned at the top, Rosie recently received the Barrel Institute Patient and Family Innovation Award. And we are so, so happy for her. And she is here to talk to us about the milestones that got her to this point. So what I'm gonna do is actually just stop sharing and we can all see each other. And Rosie, go ahead and take it away.
Hi. I guess my story started 12 years ago. It'll be 12 years on August 17th of 2009 was when I had a knee replacement that developed into a MRSA staph infection. And that MRSA staph infection led to 58 surgeries, over 200 hospitalizations, 12 episodes of sepsis, one flight for life, a coma, a couple comas, but one long coma of 6 days. I also have had 3 different amputations. So first I had my leg amputated about 6 inches above the knee. Then I had to have the hip amputated and then most of the pelvic bone. I still deal with the infection all the time, but from the beginning, I would say I wasn't even, maybe about a year into it, my infectious disease doctor came to me and said, we are having a lot of joint replacement infections, especially MRSA. And Rosie, you're handling this better than I've ever seen a patient handle this. And you seem to want to make a difference. And so we are going to do a week's study of why we're having these problems. And we've never invited a patient, but I just think you need to be there. So David and I said, okay, David literally took me every morning to the hospital where I had the original surgery, and I spent the day with him. And on Thursday afternoon, the doctor turned to me and said, tomorrow morning, we have to present our findings to leadership. And he said, I believe we can't present the findings without telling your story. And so, Rosie, would you tell your story? So when he said leadership, I thought a boardroom and maybe a few people around a board table. And I have to tell you, in my past life, I was an educator. So, speaking in front of groups didn't bother me, but I expected maybe 20 people in the room. It was a room of over 200 people. It was my first time telling my story. But that story led to every one of our recommendations, be it small or big, were provided. They went from 1 infection preventativist to 6 of them. So we increased the amount. They took down all of their hand washing signs and put up Think Rosie signs. And they began telling my story at orientation and retelling my story so that people would really think about my story when they washed their hands. And one of the things that happened from this meeting was that they were also involved with IHI at the time. And IHI was in their 4th year of a Project Joints. It was called Project Joints. And they were looking at joint replacement infections. And they weren't getting a lot of traction. Nobody was coming up with a good idea. And so this group called IHI and said, I think you need to tell Rosie's story. And so the day after I came home from my first amputation, IHI came to my home and they created what is called One Is Too Many. It's an 8-minute video that's still used by many hospitals in orientation, by many places across the world. I still get calls saying, we saw your video, would you come and talk to us? So when I look at my storytelling and how I do my storytelling, I have honed it over the years, but I have always said to people, when they ask me to tell my story, I always say, so why do you want me to tell my story? What are you working on? What are you doing? What is the purpose? Because I have to tell you, I had a few experiences where, especially with webinars early on, where they'd say, well, we need a patient story, will you tell your story? And my story wasn't connected to the webinar at all. And I was like, why am I don't need to tell a sad story, because I never looked at my story as being a sad story. And I always looked at my story as being a story that's going to be improvement. And I always looked at my story as saying, I don't want this to happen to someone else. That's why I tell my story. And so I finally, even at webinars, said, if it isn't, if you are just putting me at the end or at the beginning, just to have a story, I don't want to do it. I'm not going to do it. I'm a kind of, and I have to tell you that I've really grown that I now call it storytelling with a purpose. And I've literally created it into, and I'm going to present this process the first time at the IHI Patient Safety Congress in May. But I've developed it into a learning health system. So basically, I take my story or stories, my story or stories that I've known, and I look at that as the data. And then we look at that data and create guidance for new action. And then the action, and from that action, we collect new data from, did my story make a difference? So I'm saying to people now, it's not a one and done kind of world. I don't want to live in a one and done kind of world. I want to do what I do with Bellin or what I do at UW. I mean, I've been working with UW for 6 years. We started out with a PCORI grant. And first of all, I started out with the Department of Health and sat next to the head of the, we would always sit next to each other. Her name is Dr. Nazia Safdar, and she is the head of infectious disease research at UW and the Veterans Hospital. And we would say to each other, we need to do something. And then PCORI grants came around, and she said, will you help us write a PCORI grant? And so we wrote a PCORI grant to include patient engagement in the work that they were doing. And that's how Lois, who's on this call, got involved. And now Paul and Paul are involved in that group. But because we had a 2-year, $250,000 PCORI grant, when we changed the vision of what they wanted to do with that money. I mean, the researchers thought they were just going to get $250,000 and they were going to do with what they wanted with it. But we as patients said, no, we want you to look at the environment and what is happening and how the environment is changing. And so we really pushed that. And so our PCORI grant money ended up being used mainly for environment study and the beginning of the environment study. And then part of it was looking at C. diff, and part of it was antibiotic stewardship. So those were our 3 biggies. And basically all of those 3 things were then picked up with other grants. And I remember Lois and I sitting outside that meeting, the last meeting when the 2 years were up and we were supposed to be done, and saying to each other, but we don't want to be done, we just got started. And so I went to Dr. Nazia and said, we want to stay, we want to continue. And then she said to me, well, Rosie, would you be willing to be the coordinator and work with the group and work with our researchers and try to make the connections? And so that's what I've done over the last 5 or 6 years. And we've had, rough times along the way. We've been through a few people on the UW side who have been not always, connected with patients, and we had to, come to terms sometimes. But I have continued to work, and so has Lois, and basically, well, 2 of the people from the group died. One of them was David, and one of them was another gentleman. And then we lost one other person, but otherwise, all of the people from our original group are still involved, and we brought in some new people, and we're continuing to bring in new people. So that was one project that I've worked on, and that has been one of my prize. Another project that I've continued with is Bellin Health. Now, I have never been a patient at Bellin Health. Everybody says to me, well, you must have been a patient there, Rosie. I'm like, no, I've never been a patient at Bellin Health. What happened was I was doing a presentation for the Wisconsin the Wisconsin Hospital Association, and Bellin Health happened to get on a table that David was facilitating. So we had breakout sessions, and David always was willing to be a facilitator. He didn't want to stand in front and talk, but he would facilitate a table. And so Bellin Health made sure they got on David's table and said, do you think Rosie would come and work with us? And that was 8 years ago. And I have continued to work with them. About 5 years ago, facilities came to Shilton, which is where I live, which is about an hour from Green Bay and invited David and I to breakfast. And I can tell you that an hour and a half into breakfast, we hadn't ordered because we were talking about all the different ways that we could be involved in construction, in development of new buildings, in security and maintenance and environmental services. And so I started telling my story in a new way and to new people and to maintenance, to environmental services. I now literally every Thursday morning from 8 to noon, I literally spend with architects and construction and contractors and people from different departments, making the connections to make sure that when they shut off the water, they think about the patient and how that might affect the patient for the evening, or just look at how they put out messages when they do those kinds of things to patients. I look at how they deal with handicapped infections, infection control. I have literally now been invited to construction companies to share my story because, construction companies that do construction and renovations inside hospitals have all these rules, but they don't understand why they have the rules. And they don't understand that, one dormant molecule of dirt could create a huge infection again. And you need to make sure that you protect the hospital and all the other patients while you're doing this construction. And also how noise affects the patient, how, all the different things that happens to construction and how you can, work within the system and make it a better experience for patients. So I literally block off my Thursday morning. I, do Zoom meetings all Thursday morning with them. They also are building a new ambulatory surgery site. I've been working with the architects on that from the beginning. So I've gone in different ways but I always, it starts with my story and it continues. And so it's like telling my story with purpose, looking at how to develop that into a learning health system where we keep collecting data and creating and making better experiences for patients. And, I find that some of the toughest things to do is to break down some of the systems. I'm going to tell you the hardest area, and Lindsay's going to laugh because I still am fighting in that area, is IT. IT doesn't think patients know anything, and I presented at Epic because I did, Lindsay and I did a lot of work with Open Notes and with IT. For a while, we did a national work group, and so I presented at Epic, which they had never had a patient present, and I encouraged them to get a patient advisory console. Some of you are on that now. Ting is on that, and now they have a waiting list of researchers trying to get in front of that group because they want to share because they have the knowledge to create, but they don't have the experience. We as patients bring the experience and say, this isn't going to work. This will work. If you make one, if you change this, it might be more, it might be a better way for patients to use, especially like the MyChart and the bedside MyChart and those kind of things. So, I've jumped around. I've done a lot of different things. I do a lot of work now with measurement, and I did that in my past life. And so I'm doing a lot of work with that now because I've done it in my past life. I understand it. Yesterday afternoon, I spent an afternoon with cardiologists because, when you get an infection like this, even though I had no heart problems when this started, and I always said, I thought I survived because I didn't have cholesterol, I didn't have heart problems, I didn't have diabetes, I had arthritis. That's what's my main complaint. And I had, bad arthritis, rheumatoid arthritis. And so, but then by going into septic shock and then going into septic shock and being in a coma. When I came out, I had AFib. And so then I ended up dealing with cardiologists. And so now I do some work with cardiology, and we were looking at the measures of how they're going to be paid in the future and CMS work. And so that was, and it was interesting because, I could give scenarios of how, when they talk about, implants are costly, and I have a pacemaker because I tried all the meds and none of them worked. So I have a pacemaker and have had an ablation. And and so yesterday when we talked about it, I could very easily say, yes, it's very costly to do the implant. But now I've gone a year and I've not had one problem, and I have not had to see a cardiologist. I'm just going in once a year, and my pacemaker is being checked remotely. So I have an app on my iPhone that checks my pacemaker. I literally was in Indianapolis and had my pacemaker checked while I was in Indianapolis. I just pushed the button on my iPhone, and I didn't have to go to an appointment. So, I think that the more ways you can tell your story, and the more ways you can collect other people's stories, because that's what has happened to me, is I've collected other people's stories along the way and share those too, because that's the data that you need to move and make change. And so your stories are not just stories, but they're data. And last week, I was, the president of IHI reached out to me on Thursday and asked me to be on the call on Friday that he was doing about the woman who was charged with criminally charged as a criminal because she made a mistake with a medicine and the person died. And so they were having a discussion of how this is affecting medicine. And so he wanted me to be on the call. And he did not say to me he was going to call on me and ask me to talk. But what happened was he had a panel, and then he called on a few doctors along the way that were on the call. And at the last 5 minutes, he reached out to me and said, "You've been a longtime friend of IHI's." And I have. I presented 11 times at IHI. I presented even during COVID, and mainly have done major presentations on storytelling with them. But anyway, and what he asked me was, as a patient, how do you feel about this? And I'm like, on any given day, a mistake can be made. But I don't believe anybody in the healthcare world sets out a mistake. I always say, when I tell my story, I always say, nobody on August 17th of 2009 got up that morning and said, I'm going to make a mistake today, or something's going to go wrong today, and Rosie Bartel's going to get MRSA. But something went wrong that day, and somehow I got MRSA. But that to punish somebody, I believe the punishment belongs with the fact that they didn't report the error. With Vanderbilt didn't report it. I don't understand that. And several of the doctors that spoke talked about the fact, and nurses talked about the fact that it's very easy, and some of them have made major changes already because of this case. Because usually you had to only put in 2 letters, and then prescriptions pop up, and then you just hit on one, and it's very easy to hit on the wrong one. And that's what she did. She hit on the wrong prescription and gave the wrong prescription. And so Duke was talking about it, and they had to put in 3 letters, but they realized that even 3 letters wasn't enough. So now they've changed their system to put in 5 letters before a list will pop up. And so then the list becomes very small, and many times it's only 1 drug will pop up then. And so, and some of the doctors said, this was not an intentional error, but yet, and so you know, basically all of us, including the patients on the call and the patient on the panel, who I know her from another organization, you know, made it very clear that that was not the voice of the patient either. And it wasn't the voice of the patient, the family of the patient that had this happen to him. But, you know, I think that this is, you know, I think that the state got pushed into a corner and they hadn't done anything, and then they decided that they should do something. But I'm not sure they did the right thing. And I just feel, you know, I feel sorry for her, and I feel sorry for the family, but I also feel sorry for the medical profession because it's scaring people. You know, there's lots of things scaring the medical profession right now, but especially these kind of situations. But you know, and what happened to me was that the person who was on the panel said, Rosie, I like your idea of telling a story with a purpose, and that stories will help create change, and that this woman in this family should be telling their story, but not convicting somebody. And you know, one of the people, the person on the panel said, you know, Rosie, I'm going to use this in my future, because she said, I'm sick of people asking me to tell a sad story, you know, because she lost her husband to a medical error. But, you know, she said, I'm sick of people thinking that I should tell a sad story. And from the beginning, I never felt like I had a sad story to tell, because what happened to me, I can't change. It can't go away tomorrow. But I can change it for somebody else. And that's my only goal in life. If every time I tell my story, one person takes that story and takes it somewhere else, then that's worth it. It's worth telling the story.
Can I make a comment, Rosie?
Sure.
So this time last year, I had MRSA, and I was so scared. It lasted like 6 weeks, and you know, I was like, all I ever heard was, "You get MRSA, parts are gonna fall off and stuff," you know, like that. They, you know, the scary stuff they tell you about it. But it was really, it scared me, and I still have like a little wound at that spot, and it hasn't healed, and I'm like, I should probably go back and have that checked. Yeah. Now that I'm thinking about it, because, you know, they gave me dioxycycline and stuff like that for it, and but it still leaks a little bit. This conversation has made me decide I'm going to call my doctor and go back in and get this thing checked out.
Yeah, that was what happened with me. The wounds never healed, but they were big wounds because it was a surgical wound. And the more surgery they did, the more it didn't heal. And even with the amputations, it didn't heal. So
thank you for sharing your story, because that hit home so much.
I'm open to questions, thoughts, ideas. Hi, Greg, I see you're on.
Marty. You're muted.
Yeah, I have to unmute myself. Rosie, I just wanted to say that when you talked about the opportunity to do measurements, I was fortunate enough to be on a CMS research grant for knees and hips. It was a 3-year grant, and we were working on the measurements, and we were going to do the setup of what was important for patient expectations from surgery, pre and post.
Right.
I went ahead and did the whole survey, which was nothing like the survey that they had given us, but you know that's how it works, right?
Right.
Tell us what you want, and we'll tell you how to do it, right? And we did all of that. At the end of the day, I had a number of conversations with surgeons that really didn't like that amount of, I think, accountability. Bottom line is, when it was all over and done with, the surgeons were held responsible for the outcomes, and it affected their reimbursement, and CMS took it. So it was a big move for bringing our voices forward, but making the emphasis on this is not about them. This is about us. We need to make a joint venture with the outcomes to make sure that everything that can possibly be done, and I love the way you present it, is that you're going to hopefully have the right outcome because you're going to have all of the right measures, but things happen.
Right. And, you know, that's one of the things that I keep bringing up at the CMS work. And you know, because I worked on the sepsis one, and the last time you know, the time when I was in the coma and when I was flighted. So it had been after my hip was removed. I was home about 5 days, and in the morning I said to David, I don't feel really good, and I have a doctor appointment tomorrow. I think, and we were going to Freighter, which is about an hour and a half from our house. So I said to him, I think I'm going to pack a bag. I'm afraid I'm going to end up staying. And so basically, as the day went on, I wasn't feeling good. And then in the afternoon, I was sitting in a recliner, and I put my hand down and I pulled it out, and it was all blood. And I said to David, I'm bleeding. And he said, well, let's get you in your wheelchair and let's see what's going on. And so he got me halfway in the wheelchair, and it's gushing blood. And so he calls 911. And because I had been transported by ambulance a number of times in this community, and I live in a small community, the guys, when they came, they said, we're used to taking you to Appleton, Rosie, and we have a little hospital in our town in Chilton. It's a 21-bed access hospital. And they said, but today we aren't taking you to Appleton. We're going to be lucky if we get you to Chilton, which was 3 blocks from my house. And so they took me to Chilton, and David closed up the house and came over to the hospital. And by the time he got to the hospital, they were already giving me blood, and they were ready, you know, giving me fluids, and they had already called Flight for Life. So David walks through the door, and they said, we've called Freighter, we've called Flight for Life, and we're on, you know, so they're on their way. And so basically, within an hour's time, they had given me 3 units of blood, and they were sending 2 units with Flight for Life. They asked me twice if I wanted to live, because my blood pressure was so low that they didn't think I was going to survive the flight. But they kept asking me if I wanted to live, because if I chose not to live, then they wouldn't put me on the flight. And I kept saying, yes, I wanted to live. So they put me on the flight. And the thing I always talk about is the fact that during the flight, I was asked twice if I wanted to live. And I kept thinking, so if I say no now, are they going to set me down in a cornfield and leave me off? You know, I'm like, you know, this is a dumb question once we're flying in a helicopter here, you know. So then I get to Freighter, and when I got to Freighter, they were prepared. I mean, the emergency room was prepared. My surgeons, the residents, you know, from that department were prepared. And so my story is, you know, one of the things that they kept talking in sepsis, who would get the blame? Who would get pinged for this? Which hospital would get the risk, you know, or which? And I said, well, you know, if I died in flight, you know, the hospital that was the 21-bed access hospital, that emergency room did everything right. The hospital I was going to was prepared to do everything right and did everything right when I got there. But, you know, if I died in flight, basically this started, you know, like 5 years before this or 6 years before this. And why would they get the results? Because what happened was it had nothing to do with my wound from the amputation. what happened was the MRSA ate through an artery next to the amputation. And that's what was bleeding. And it was, and I mean, my doctor he was so funny because he said, when they got me on the table and I had a vac and they took off the vac, he said he was covered with blood from head to toe. He said it was like a movie. He said, and he jumped on the table, his resident and the nurse, and they all were putting pressure on and looking for where the blood was coming from for the bleeder. And he said he had already called vascular in because he couldn't figure out what to do. But by the time vascular got there, he had found the bleeder and he had tied it off so that it had stopped bleeding. And so when that was it, they had done, that was 1:30 in the morning that this happened, they took me to surgery. And 4:30 in the morning, he told David that he didn't know if my mind was going to be okay or my kidneys. And then I spent about 6 days in a coma. And when I came out, I mean, David knew my rule. My rule was, as long as I had my mind, I was going to fight. But if my mind was gone, I wanted, then let me go. And so I think he spent the 6 days trying to decide what to do if my mind was gone. And, but, I remember that my daughter coming with my iPad, and she was trying to answer questions on my iPad while I was in the coma. And Stephen Hoy was Stephen and I were going to do a workshop at IHI Forum that year. And so he and I were communicating, but David didn't know about us communicating. And so when Shelley came in with the iPad, she goes, "And who is this Stephen that you're talking to? He's really young, Mom. Who is this young guy you're talking to?" And I said, "Well, he's a guy I'm doing a workshop with." And so and she started crying, and I said, "Why are you crying?" And she goes, "Well, I think your mind is just fine, Mom, because you know who Stephen is, and you know exactly what you're doing with him." And she said, "Well, none of us could figure out what was going on with Stephen." So, it was those kind of things that, happened. But that experience says to me, when all things go right, then those measures work fine. But sometimes when those things don't go right, and when we were working with the cardiologist yesterday, and I even stayed on at the end, and because one cardiologist was really, really candid and very upfront, and kept telling us, saying, and why wouldn't we use the best devices we have, and why wouldn't we give the best medicine we have, and why would we want to look at cost, quality of life, and I said to him, I appreciate the fact that quality of life was more important to you than worrying about the cost, because, and I told him, I said, I believe that I was costing more money before, because I was in and out of that, cardiologist, and in and out of the hospital with this AFib before I had my pacemaker. But since I had my pacemaker, and once they had it regulated, set to the level it's set at now, I've gone a year without seeing a cardiologist. I have an appointment in July because it's a checkup, but otherwise I've just, they've taken I've given the reports, and that's it. So, yes, there was a big expense, but no, I haven't had hospitalizations. And I believe hospitalizations are bigger expenses than having a device in the end. Just like, Eliquis is the blood thinner that I'm on. And, warfarin and Coumadin were, the ones that of the past, and many people still use those. And some of the doctors there felt that that's what they should say, and Eliquis should not be being used. And I said, my theory is, but yet with warfarin, you have to have blood work and labs done all the time. So you bump the cost back to the patient, because a lot of times the lab work is not covered, or part of the lab work isn't covered. So now you're bumping costs back to patients. So, you know, so I said, you know, yes, Eliquis is expensive, but it's the better of the choice. And especially for somebody like me who is in a wheelchair, who has to, you know, find somebody to go with her at this point to, you know, to a doctor appointment or somebody to take them. You know, it's an inconvenience. So.
Thank you for sharing.
So I think that, you know, the measures are one of two ways. And I believe they're important, but I think that we have to understand that we have to keep our voice. Libby said to Mary and I that make sure you tell your stories and make sure you get your voice heard yesterday, and we did.
I love a comment in the chat from Marty. Says N is number, but an N with a narrative is a compelling story. I love that. We also have a question in the chat from Lindsay. She says that you're so able to share your really vulnerable parts of your story in a way that ignites improvements. What is one thing you would say to someone who may be hesitant to share their own vulnerable parts of their story?
I think you have to know when you're ready to share your story. You know, I was ready earlier than a lot of people, and that's what the doctor saw in me. David wasn't. I remember them trying to get David to tell part of the story when they came to IHI, came to the house, and he went to pieces. And I mean, David, when I told my story, to the very end, you know, up until the time he died, I always said to him, I knew I would when I did a really good job, because he still cried when I told my story, you know, because, you know, as a caregiver and as my husband, he knew the you know, the struggles that my life was, and so he still cried, and I used to tease him because if I could make him cry, then I knew I did a great job. and so, and I think, you know, some people looked at COVID as being a horrible time, and it was hard for a lot of patient advisors. But for me, it wasn't, and part of it was the Barrel Institute, because they, you know, I was on the Global Patient Family Advisory. And so part of that I had started presenting across the world. So during COVID, I have done virtual presentations to 6 of the 7 continents. Some of them through Barrel, some of them through some of the other. You know, somebody hears a podcast somewhere, and then, you know, they asked me to do a podcast. And so all of a sudden Copenhagen was asking me to do a podcast, you know, about, because they had heard of a podcast I did, a spotlight podcast on infections that I did here in the States. And so then Copenhagen asked me to do a podcast for Europe. And so, and that's, you know, that's been the way that things happen. Plus that video that IHI did. And when I look at that video, I think, oh my God, was I raw? I mean, my emotions were still just like right below. And, but I think that, you know, I look at that video and think I was raw, but other people look at that video and it's like a starting spot. And then they ask me to come and present and tell the rest of the story. Because that video was done, you know, before or just as my amputations were starting. One of the other things is that, you know, everybody has a ritual when they tell their stories. You know, like I can't eat. I don't care if I'm telling my story at 8 o'clock at night, I can't eat that day until after I tell my story. If I put food in my stomach, I'll be sick. And so, you know, and I also like, I write a few words down, but I don't write it out. Some people write out their story. I can't do that. I put a few words down, and then I kind of go over it and over it in my head. But when I get to it, it's like whatever moves me, who, you know, even virtually, I connect with the people who are there, and then I think this is what they need today. You know, when I did in person or do in-person presentations, I would connect with certain people, you know, and connect with them in the audience. And that was easier, but I've learned how to do that virtually. You know, as long as people turn on their cameras, you can do that virtually. It's when people don't turn on their cameras but I you know, I think that you have to figure out what works for you. You have to be ready, but don't be afraid. You know, some people think, oh, my story isn't important enough. It is. Your story is important. And I kind of thought that in the beginning. And you know, when even like yesterday, when I told parts of my cardiac story, I'm thinking, yeah, well, this is really, they probably think this is worthless. And yet when I stayed on in the end, he said, your stories are helping us make decisions that we would have never made. And I think, you know, that's what you have to look at is how is your story going to make a difference? And then it empowers you. And I remember the first time I told my story to a room full of maintenance men, and I mean 7 o'clock in the morning, a room full of maintenance men. And it was the first time I did anything with facilities. And I guess I didn't think about it when he asked me to talk to maintenance that it would be a room full of men. You know, it didn't click in my brain. And all of a sudden I looked up and I said to David, I'm the only woman in this room. And I now have to tell my story. And some of these guys are either coming into work early or having to stay late. And I'm you know, this is not their normal routine. But it was interesting because after I told my story, a young man came up and asked the head of facilities if he could share his story about their experience in maternity, because he and his wife had an experience in maternity that he felt they could learn from. And so he asked if he could share his story. And the other thing that happened, and this is a story that the director of facilities, he and I have done presentations at IHI about the work we're doing together, but he tells this story. So there was a maintenance man in the group who probably says 10 words in a day. You know, he'll say good morning, good afternoon. He'll say how, you know, but he probably says a total of 10 words a day. So they were dealing with a surgical suite where the nurses and the doctors kept putting a cart in front of the air exchange. And the maintenance men would move it, and the next day the cart would be in front of the air exchange. And so this had gone on for about a week. They had asked them not to put it in front. It still got put in front of the air exchange. And so one of the maintenance guys said, maybe we should just let it go. You know, we're not getting anywhere with this. We should just let it go. And this man who says less than 10 words a day said, and what would Rosie say about this? And it literally made them go to leadership and say, we have a problem here. We need to figure out how to solve it. We need to get the people at the table to discuss this. And they need to understand that if we don't have good quality air exchange, somebody could get an infection in this room. So, you know, that's the kind of things that makes the difference. That's the kind of things that that's the kind of change I want to see, you know, those kind of things. So, you know, hand hygiene, you know, it was interesting. I was on a call a couple of weeks ago and so the water is going to be turned off and, you know, so the infectious disease person was saying, you know, I'm a little worried about hand hygiene, especially because this is maternity and we're, you know, never know what happens in maternity, even in the middle of the night, even though it's 9 o'clock at night. And so they said, well, as long as we're gloved, we should be okay. And I said, well, wait a minute. So you're saying that if you're gloved and your gloves get soiled and you take them off, then gelling is, all you need to do is gel. And she said, yeah, that's the way we were taught. And I'm like, well, that's not, and the infectious disease person right away said, that's not the rule. If your gloves get soiled and you have to take them off, then you have to wash your hands with soap and water. So, basically we've got in portable hand washing stations to be put in in several strategic locations along that unit that's going to have the water shut off so that they can wash their hands, and flushing toilets. They brought in bottles of water for people to wash their hands. They brought in buckets of water, like to flush toilets. I mean, we came up with a whole process that's going to make it, much more convenient. It happened last night. I can't wait to hear what happened if everything went well.
Yeah, that would be very interesting to hear.
Yeah.
Well, thank you, Rosie. We're just getting to the top of the hour. So thank you for sharing your story and your advice and inspiring us all to get involved and share our stories. I'm definitely inspired to share my story more now. So thank you again, and congratulations once again. Keep saying it over and over again, but you deserve all the awards, I think.
Well, thank you. I have to tell you, when they called me to tell me I was going to get the award, I was like, it was one of those times where I couldn't talk. And I'm like, that doesn't happen to me real often. As you guys all know, I'm a talker. But I just was like, and then what you don't see in that video is what Jason said. And that meant more to me probably than the video, because Jason said, I don't know if I can hold it together to give this award. And that was, and then he said that we've been longtime friends, and I've known Jason for 11 years. So I met him at the first IHI conference I went to. So
thank you,
Rosie.
Thank you, Rosie.
And just as a reminder, if you have a topic or anything you'd like to share with the PFA network, just like Rosie did today, if you have a discussion, if you need resources, or if you need advice from the PFA network, feel free to get in touch with me, or you can fill out this form. I'm going to put the link right there in the chat. It's just an interest form that will kind of help us get the coffee chat set up for you. I'll also put my email chat there. Feel free to email me with any questions, or if you're interested in sharing a coffee chat. So thank you all for joining us, and we will see you all next month.
Thank you.
Thank you.
Take care, everyone.
Thank you for having me. I really appreciate it.
Of course, anytime.
Bye-bye.